building units for the bones. And then we have two types of bone cells or osteocytes. One are called osteoblast and osteoclast. So blast means formation and clast means eating, because it eats the bones. So they are in balance till we reach 30 years of age. 30 sana. After that, osteoclast goes up and osteoblast goes down. Okay. Osteoporosis is the disease primarily of females. I don't say that males don't suffer from osteoporosis. We have here one male doctor, I will not disclose his name. He is suffering from osteoporosis. He is male. But yeah, common problem in females. Almost all females, unfortunately, they suffer from osteoporosis sooner or later. Means when they reach 60 years, 65 years. So there are many factors and we will look into that. I don't know whether you started it in pathology. We classify osteoporosis into two, primary and secondary. Primary one is that is in the females, and the other one may be in secondary, senile, age related. In males, if it is there, then it will be most probably in late, maybe after 60 or 70 years of age. So, but still, again, greater number in females. Treatment, prevention. Prevention is the best option in the treatment or in the management of osteoporosis. As we will see in our coming slides, and inshallah when you will start your clinics in 4th year and later on in your life, especially female patients, you will see they will be using these drugs and they will be telling you, doctor, we are using it for the last 10 years, for last 15 years. So that is prevention. That is prevention, because just to save or to prevent bone loss. So to prevent bone loss, to promote bone formation, and all the three require adequate calcium and vitamin D. This is very important, that if you remember, we discussed also in iron deficiency anemia, or in anemia, that there are 3 types of anemia which we face in our clinics, and the most common is iron deficiency anemia. Sometimes you will find patients, they are suffering from vitamin B12 deficiency anemia, and very rarely folic acid deficiency anemia, very rare. What is important, the point that I am going to make, that 2 vitamins are very important for us in clinics: vitamin D and vitamin B12. Vitamin D and vitamin B12. I don't know, inshallah, when you will be teaching after 10 years, maybe more vitamins are included, but today these 2 vitamins are important, and I hope you already discussed with Dr. Fathi, because he likes vitamin D like anything. Most of us are deficient on vitamin D, especially in Middle East, maybe problem with sunlight rays, ultraviolet rays that we should receive, lifestyle, all these things. But most of us are deficient on the vitamin D. And then you know that calcium and vitamin D, they go together. They are like car and tires, kafarat. So if you have Mercedes and this car doesn't have tires, so Mercedes means nothing, useless. So the same, if you take one and you don't take the other one, so they help each other because vitamin D is required for the calcium. So you see even when you go to the grocery and check any halib, like Al-Marai is very famous, you will find it is written fortified or supplemented by vitamin A and D. Why? Because that is required for this. Anyhow, we go to pharmacotherapy of osteoporosis. First one is calcium. Second one is vitamin D. Third one is BPs or bisphosphonates. Fourth one is calcitonin. Fifth one are HRTs. Then we have serums. Then we have PTH. And then we have monoclonal antibodies. As we discussed in the previous slide, that calcium and vitamin D, they are very important in the treatment as well as in the prevention of the osteoporosis. So, whenever a patient is diagnosed, as today inshallah you will discuss in the case, with osteoporosis, and if there is no serious thing like no fracture, nothing like that, only she is, because mostly females, suffering from osteoporosis, the best option is we should start with calcium and vitamin D. We should start with calcium and vitamin D. As you discussed with Dr. Fathi, in biochemical markers, the calcium levels, ionized, unionized, conjugated, unconjugated, total, they are required. They are done, they are performed to check whether there is hypocalcemia or not. Even if there is no hypocalcemia, still, the protocol of the osteoporosis treatment starts with calcium and vitamin D. But here one thing you should keep in mind, as we discussed, that these are elderly people, elderly patients, 60, 65, 70 years of age. And this is the age where mostly the patients are the people, they suffer from comorbidities. Like you will see the patient will be suffering from diabetes mellitus, type 1 or type 2. Might be suffering from hypertension or blood pressure high. Might be suffering from hypercholesterolemia. So in that case, what is important for us, that we will give a gap when we take calcium with other drugs. Why? Because calcium reduces the absorption of other medications. If you take it together with other medicines, calcium will reduce the absorption of other medications, like you are taking it together with antihypertensive, the drugs which are used to treat blood pressure, or you are using it together with drugs which are used to treat diabetes, and you don't care. And what happens? The patient is taking it together with calcium. After 2 weeks, the patient will come back to you and will be telling you, doctor, my blood sugar level is going up. Why it is going up? Why? Because the patient is taking it together with calcium, and calcium can reduce up to 50%. 50 bil mia absorption of the drugs. So, what is best thing, that at least 2 to 4 hours gap should be given when we use calcium with other drugs. That is very important. Why? Because you will see this quite commonly in practice. Bisphosphonates, as we will discuss it in details, bisphosphonate is like alisaud. Bisphosphonates are ruling the treatment plan which are used for osteoporosis. You will never see any patient who is diagnosed with osteoporosis and is not taking bisphosphonates. No patient. All the patients, they have to take, maybe sooner, maybe later. So they are ruling. Even today they are ruling. All others you will see maybe using for certain duration, but they are using for lifetime in many cases. We will go into details. They are very interesting drugs. Next is calcitonin. Calcitonin, where is marker? No marker? Okay. I think you discussed with Dr. Fathi also, calcitonin our body produces itself. Calcitonin and parathormone. Calcitonin our body itself produces to regulate the calcium metabolism. But what happens in case of osteoporosis, this amount is not sufficient that our body synthesizes and utilizes. So we need calcitonin from outside. Interestingly, when we were discussing pharmacology some 25 or more than 25 years back, calcitonin was the drug of choice. Calcitonin was the drug of choice. Bisphosphonate was just entering. Only one bisphosphonate, first generation, that was just entering. It was in the trial. At that time, calcitonin was the drug of choice. Today, if you ask any rheumatologist or orthopedic surgeon who is dealing with osteoporosis, they say calcitonin is no more anti-osteoporotic drug. It is only analgesic. The point that it is taken from Solomon. What is Solomon? Samak, fish.
Oh, Solomon.
You like it? You don't like it. I think Egyptians like it. All of them all the time discussing Amdaw, some restaurants, there are different type of fish. Isn't?
Yes.
Okay. You also go there? No? So, the source for calcitonin is Solomon fish. Some people say salmon, some people say Solomon. That is the source for calcitonin. We will go into detail. Next is HRT, or estrogens. HRT. What is HRT?
Hormone replacement therapy.
Hormone or hormonal replacement therapy. And one of them is estrogen. So you can understand that it is only used in women or females. And as you will discuss today in case, or you might know already, that females in their reproductive life, that starts from 11 to 12 years, and what we say periods or menstruation or the menstrual cycle starts. And two hormones, they are important in the menstrual cycle. One is called estrogen and the other one is called progesterone. Testosterone is for men. Progesterone. Okay? So, estrogen is also giving support to calcium to stay in the bones. Estrogen helps the females to stay the calcium in the bones. And you already know that bones are the reservoirs, khazan you say, for the calcium and phosphorus. Okay? As females need more calcium, especially when she gets pregnant, when she is lactating, so she needs more calcium. So the calcium, if she is not taking from outside, so what will happen? It will come from the bones. It will come from the bones, one thing. Second, as you may know, multiple pregnancies. Multiple pregnancies. So whenever there is pregnancy, the menstrual cycle is stopped. Menstruation is stopped. So menstruation stopped means estrogen, progesterone stopped. So what will happen? Again, as we discussed, estrogen protects the bones to save or to reserve calcium. So you remove the shurta because estrogen is shurta. It is preventing or protecting the bone to release calcium. So what will happen? Greater number of pregnancies, more likely osteoporosis. Got my point? If the female got 4 pregnancies, it means she will more likely suffer from osteoporosis. Why? Because 4 times the estrogen blocked or stopped. Got my point? Okay, now here estrogen is given and it is effective when it is given soon after menopause. You know menopause. Meno means blood. French, meno means blood. Pause mean, pause even in computer, in smart devices. Stop. When there is no bleeding. And that may happen 47, 49, 50. In European countries, 55. What does that mean? That the female is no more able to reproduce. She will be unable to reproduce, to give birth to a child, because menstrual cycle is important for the pregnancy. Okay, so when menopause stops, that means no estrogens. So first 5 years after menopause, for example, the menopause starts by 49 years, so 49 plus 5, how much it will be? 54 years. So first 5 years are important to save or to protect the osteoporosis. And one of the drugs that can be used is estrogen or HRT, hormonal replacement therapy. We have 2 types of HRT. One is oral, tablets, tiny tablets. If you go to any pharmacy and ask, give me, they are called oral contraceptive pills also. And the other one are injectables, injection. So mostly in case of osteoporosis, oral tablets or pills are used. But the problem with estrogen, because we need them for longer duration, maybe 1 year, 2 years, 3 years. So it has its own side effects. Own side effects, nausea, vomiting, okay, that can be managed. But it can lead to Dr. Ali's favorite cancer. So that is the problem. And for this reason, we don't use it very frequently nowadays. It can cause cancer of the uterus, it can cause cancer of the breast, it can also make problems in the blood. DVT. DVT. D for doctor, V for veterinarian, T for treatment. Mafi? DVT, very important thing. You will find patients in your clinic, and I think we discussed somewhere, aspirin, clopidogrel, antiplatelet, anticoagulant drugs. DVT means deep venous thrombosis. It increases the coagulation. It increases the coagulation. So deep venous thrombosis. It can cause deep venous thrombosis. So for this reason, we don't use it unless there is no other option. So when this problem came out that it can cause cancer, they found, okay, we should work on another drug, and that is called serums. That is selective estrogen receptor modifiers. That they will act in a different way. They will not affect the uterus, they will not affect the breast. So, because these two cancers, they are quite common, cervical or uterine, as well as breast cancer in females. But the one problem is still there, that is DVT. DVT is caused both by estrogen as well as tamoxifen, that is used instead of serum, instead of HRT. Yes, in serum, the malignancies are less because they are acting in a different way, sparing or antagonizing, but DVT is there. Deep venous thrombosis is there. So, we normally don't use it in the management of osteoporosis unless there is no other option. PTH, thyroid hormone or parathormone, both way you can say. And the last one is monoclonal antibodies. Okay. Calcium and vitamin D, lifelong companions for healthy bones. As you know, teeth are also bones. So many times you also advise to your patients to take calcium and vitamin D. Classification of the bisphosphonates. Sorry, there was some problem in the rearrangement in the PDF file. What I was telling when we were studying the drugs for the osteoporosis, just the first generation was entry, and that was atidronate. We classify the bisphosphonates into 3 generations, and this classification is based on potency and sometimes duration of action. What do we mean by potency? That we need smaller dose or larger dose? Smaller dose, good. We need smaller dose of the drug to get the same benefit. Like in this case, you will see zoldronate only 4 milligram and atidronate maybe 500 milligram. 4 milligram and 500 milligram. So such a big difference.
The zoldronate is once a year, right? Not all the.
Yeah, it's once a year. Now, first thing is potency. That we need smaller dose. first generation that is atitronate. You can cross it. We normally don't ask an exam because we don't use it anymore. But at least, because if you say second generation, so definitely it comes to your mind who is first generation. So for this reason we just put that there is first generation. Second generation, alendronate oral and abandronate oral as well as IV. In the PDF, oral is missing. Maybe in the rearrangement it is gone. So you add oral to abandronate. First one, alendronate, that is used only oral. And the second one is abandronate, that is used oral as well as IV. Okay? Then we have third generation. In third generation, first one is risdronate and the second one is zoldronate. Look, you will find one thing common, and that is nowadays very famous everywhere. Drone. You see, every drug carries drone. Alendronate, then risdronate, abandronate, zoldronate. So if you just try to recall, drones are there. Another important thing that these bisphosphonates, they are used for the treatment and prevention. Treatment and prevention. You will see later on drugs which are only used for treatment. But bisphosphonate is used both for treatment and prevention. One thing. Second interesting thing about these bisphosphonates, they are used once a day, once a week, once a month, once in 3 months, once in 6 months, once in a year. Got it? No. You will find patients coming to your clinic will telling you, I take a drug once a year. So it could be zoldronate. The patient will tell you, doctor, I am suffering from osteoporosis. I take the drug once a month. Maybe abandronate. The patient will be telling you, I take a drug once a week. Maybe alendronate. The patient will be telling you, I am suffering from osteoporosis and I take the drug daily. Alendronate. Alendronate is used once a day or once a week. Once a month, abandronate. Once in a year, zoldronate. So, all these options are there. One thing. Why it is like this? Because you see, we discussed in general pharmacology that the drug must go out from the body. Half-life, while we were discussing half-life, we discussed that the drug must go out from the body. Maybe 1 day, 2 days, 5 days, 1 week, 1 month, but it has to go. Because if it continues to stay in the body, in the blood, then there will be toxicity. But interestingly, what happens in case of bisphosphonate, it disappears very quickly from the blood. When you give the patient alendronate, zoldronate, abandronate, maybe within 1 week it disappears. But it is still effective. So where does it go? To the bones. Very good. Because the site of action for the bisphosphonates is bones. So very quickly it disappears from the blood, but it continues to stay in the bones. Okay. So I will tell you interesting thing when we will go to the adverse drug reactions, how long it can stay in our bones. Mechanism mechanism of action of bisphosphonates, it has strong affinity for calcium phosphate. That is called in biochemistry hydroxy. Who will tell? Appetite, mashallah. Good. Hydroxy appetite, mashallah, mashallah. Females didn't answer. Hydroxy appetite. That is the calcium phosphate where these receptors are found. And it has strong affinity. They are strongly bound to these hydroxyapatite. Okay. When they are bound to these, they accumulate in the bones. Now next step starts. Next step, as we discussed in the beginning, that we have two types of bone cells, osteoclast and osteoblast. As we grow or advance in age, osteoclast increases. Now, what happens that these bisphosphonates, because osteoclasts are a type of proteins, they are prevented, they are blocked by bisphosphonates. How they block? By blocking an enzyme that is required for the synthesis of osteoclast. And again, you discussed it quite in detail with Dr. Fateh in cholesterol metabolism. HMGCoA. That is the enzyme that is required in the metabolism or synthesis of cholesterol. The same enzyme is required in the pathway of the osteoclast synthesis. So what we do, by giving this drug, it goes to the hydroxyapatite receptors, it goes and sits on the osteoclast. And what it does, that it prevents the enzyme that is required for the protein synthesis. HMG, 3-hydroxy, 3-methyl, gluteryl, coenzyme A. We don't need it, you may need it in biochemistry. Here we need HMG CoA reductase. This is the enzyme that is required for the conversion or in the synthesis of the osteoclast. So that is interrupted, that is blocked, and by this what happens, that it inactivates osteoclast. Why? Because this is required for its synthesis. And by this way, the apoptosis of the osteoclast is increased. Apoptosis means death of the cells. Which cells? Osteoclast. So more osteoclasts are dying, and you don't like to kill anyone. But here you are killing the cells. Why you are killing these cells? Because they are damaging. And we want the balance between osteoclast and osteoblast. We cannot increase osteoblast by this drug. So what we do, we decrease osteoclast. So that is the mechanism of action. Remember, any drug that interfere with the osteoclast, that will call anti-resorptive drug. Anti-resorptive drug. And this is the most effective anti-resorptive drug. Bisphosphonate is the most effective anti-resorptive drug. Okay, now uses. Bisphosphonates are cornerstone in all types of osteoporosis. Cornerstone, you understand. This is the basic, what I told, it is ruling like Alisaud. There is no treatment plan complete without bisphosphonate. If there is contraindication, for some reason the patient is allergic, patient cannot take, that is different story. Otherwise, we use this drug as drug of choice in the treatment as well as prevention. Okay. All types of osteoporosis, as we discussed in the beginning, most common is post menopausal, after menopause. Second one is age-related. Age-related is both for males and females. Again, more in females, but both can suffer from osteoporosis. Third one is idiopathic. Idiopathic means, if you remember in the beginning I told, idiopathic means where the reason is unknown. Very good. So we just joke where both the doctor and the patient are idiots. Idiopathic. No one knows the reason, but even if we don't know the reason, the best option is bisphosphonate. Last one, that is steroid-induced osteoporosis. Inshallah, we will discuss steroids in endocrine. One of the most commonly prescribed drug in dentistry. One of the most commonly prescribed drug in dentistry, steroids. They are also prescribed in medicine, but in dentistry, you know, you don't prescribe many drugs. But analgesics, local anesthetics, antibiotics, and steroids. So, what the steroids do, that they interfere with the calcium metabolism. They interfere with the calcium absorption. So, by this way, steroids can also cause osteoporosis. Who can suffer more from osteoporosis related with steroids? Which type of patients? Who will tell me? We discussed already. What is this? Asthma patients. Why? Because you know asthma patients need inhaled steroids. Even inhaled steroids can cause osteoporosis because the patient needs to take it for a very long time. So, any type of osteoporosis, we start our treatment and later on continue for the prevention with bisphosphonate. Okay, then we treat hypercalcemia. Hypercalcemia. Here try to understand. Mostly hypercalcemia like situation happens in malignancies. So you see here we discussed, that you will find a patient who will be taking ibandronate IV. Normally, ibandronate IV is taken once a month. Once a month. You will find a patient and she will be telling you, look doctor, I use it daily. IV and daily. So what does that mean? She is not suffering from osteoporosis. So she is using for maybe osteomalacia, maybe hypercalcemia, maybe some malignancy. Why? Because high dose, frequent dose, bisphosphonate is used, ibandronate is used in malignancy conditions. Okay? Then we have another metabolic bone disease that is called Paget's disease. The bones, they are deformed, they are becoming bigger. You might have discussed with Dr. Ali. And here again, the drug that is used is bisphosphonate. It is very important. So we have 3 uses for bisphosphonate. First one is osteoporosis. Second one is hypercalcemia, whatever is the reason for hypercalcemia. And third one, Paget's disease. Okay, these are the 3. So if you get question only for osteoporosis, then you will say postmenopausal, you will say age-related, you will say idiopathic, you will say steroid-induced. 4 for the osteoporosis. Any type of osteoporosis, we will start with bisphosphonates. Okay, now we come to adverse drug effects. Bone. bisphosphonate associated osteonecrosis of the jaw, and that is directly related to you. What happens, especially when we use ibandronate IV, that it will cause osteonecrosis. What do we mean by osteonecrosis? Death of the bones. That is important. If the patient comes to your clinic and tells you, doctor, because now you see in government hospitals the system is centralized, you just click and you find everything. So if you look for the medical history and she is suffering from osteoporosis and she is using, for example, ibandronate IV, what you will do? You will ask the patient, go back to your rheumatologist or orthopedic surgeon and stop ibandronate and then come back. Why? Because if you start with, while using ibandronate, it causes osteonecrosis of the jaw and you may break many bones of the jaw. So you are not a good doctor. So what you will do, you will ask to stop ibandronate. And what is this stopping? We will look in the last. Okay, next is esophageal erosions. Oral, because you see, you will find patients in your clinic, they will be telling you, I am using this drug for the last 10 years. For the last 10 years means she is using it for prevention. 10 years is not treatment. So, and it is oral. Here one thing is important, that is, inshallah, you will be discussing also in third year with Dr. Ayman, that whenever the patient takes bisphosphonate, it should be taken on empty stomach. Why on empty stomach? Because bisphosphonates are best absorbed in acidic environment. Bisphosphonates are best absorbed in the acidic environment. Second, you will ask the patient, because they are taken in the morning, the empty stomach is in the morning, you will ask the patient, don't lay down, don't go to bed after taking bisphosphonate at least 30 minutes to 1 hour. Two things, either the patient should walk, or if she cannot walk, then sit upright, like all of you are sitting upright. Why? Because if the patient lays down immediately, the particles of the bisphosphonate comes up to the esophagus and it causes esophagitis. And sometimes this esophagitis is very difficult to treat. So that is with the oral. Okay, now there is drug holiday with bisphosphonate. That is very interesting. This is one of very few drugs that you can miss. Like you see, the doctor tells you never miss the dose. If you have a patient, she is osteoporotic patient, you plan a dental procedure, you can give holiday. You will ask the patient, go back to your rheumatologist, ask, I am going for some dental procedure. So the doctor will tell you, okay, you can stop it for 1 month, 2 months, 3 months. Maafi mushkil. Why? Because when it was discovered in 1995, the first atidronate was introduced in 1995, some 30 years back. Then they started research on it. And you know, especially non-Muslims, they volunteers. You understand volunteer. They say, okay, you can take my body and you can do anything. So some people volunteer. Okay, you can do research on our bodies and look the effect of the bisphosphonate. It was started in 1998, 3 years after its introduction. So what happened, it was given to many patients, 2 of them died, not because of bisphosphonate, they just died of some other problem. Because they were given the dead bodies, you can do anything. So what they did, they checked the amount or the concentration of bisphosphonate after 1 week. Very good concentration was there. Then they checked after 1 month, then after 3 months, then after 1 year, then after 2 years, then 3, then 4, 5, blah, 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 up to 10 years. And still bisphosphonate was there in the bone. Bone that is dead bone. That is dead bone, and still very good amount of bisphosphonate was there. The take home message that we can take holiday, we can stop it for certain duration, and we can convince the patient, don't worry, it will work. It will work. So that is important to us. Next, denosumab. If you remember, and I think you are also discussing here with Dr. Abdurrahman also, immunology. If you remember, we discussed somewhere, any drug that is ended by suffix mab, M-A-B mab, that means monoclonal antibody. Monoclonal antibody. One of the reasons for the osteoporosis, they say that it is rankle. It could be related with immunology, with the immune system of the body. So, anti-rankle monoclonal antibody, denosumab, is also used to treat, please, not prevent, to treat osteoporosis. We use it for the treatment of osteoporosis. Okay, what happens? It binds to the rankle. What is rankle? Receptor activator of nuclear factor kappa B ligand. You don't need to recall this receptor activator, just rankle. Rankle, they are blocked by denosumab-like drugs. So when they are blocked, what will happen, that it will block the process of the synthesis of osteoclast. Because osteoclast becomes mature, first it will proliferate, then it will differentiate, and then it mature. So these 3 processes, they say that this is based on the rankle. That is based on the immune system. So we block these processes, and by this we block the osteoclastic activity. So it also increases bone mineral density.
The same action, it has the same action of bisphosphonate, right?
No, but but here it specifically acts on the receptor activator. In case of bisphosphonate interferes with the protein synthesis.
But the same
action is
result,
same.
The same result.
The result is same. The osteoclasts are reduced. Here another thing happens, that it also acts on the osteoblast. So any drug that will act on the osteoblast, that will increase the bone mineral density. You will discuss today in PBL case. What is bone mineral density and how we measure it by DEXA. There is a X-ray that is called DEXA. Administration, how many times we take it and how we take it. Subcutaneous injection every 6 months. Subcutaneous injection and every 6 months. And maximum we can use it for 2 years. 2 years, that's it. Because beyond 2 years we don't know what could happen. So that is important. Adverse drug effects, infections. Why does it cause infections? Who will tell? Monoclonal antibodies. Any monoclonal antibodies will cause infections, bacterial infections. Why? You discussed it in immunology. Monoclonal antibodies, because it suppresses the immunity. We are discussing rankle, they are suppressing. So because they are suppressing the immunity, immune response, so what will happen? There is more chance for infection. So sometimes we should keep it in mind that, and the second one, it can cause skin reactions. Again, skin reactions may be due to its effect on the immune system. So both, whether they are causing bacterial infections as well as skin reactions, they are related with, or you can say, immune mediated. Okay, calcitonin. What I told that today they say it is no more used as anti-osteoporotic drug. It is analgesic, but it was very effective 25-30 years back. It is still available. I don't say it is not available, but not as good. Again, it is treatment. This is second drug that is used as treatment. Denosumab first, bisphosphonate, but bisphosphonate is also used for the prevention. Denosumab and calcitonin, they are used in the treatment. IMSQ intranasal, IM intramuscular, subcutaneous, and intranasal, even sprays are available. So all three things are there. What we discussed, that the calcitonin that our body synthesizes is not sufficient. So what we do, we take it from the outside source, and that is salmon fish. And that salmon fish is more than 100 times more effective than the our own body calcitonin. So it inhibits osteoclast motility, first one. And second thing that is important, it inhibits reabsorption of calcium in kidneys. So what will happen to the calcium? Where the calcium go? Because the kidneys don't allow.
Urine?
Doesn't. Very good. Urine, because the kidneys don't allow. Normally, as you discussed in renal, that most of the things are reabsorbed. Those which are not reabsorbed, they will go out with urine. So here it inhibits the calcium reabsorption from the tubule, from the nephron. So what will happen, that it will go out from the body. So that is second mechanism. It acts by two mechanisms. First one, it will reduce the osteoclastic motility or movement, and second one, it increases the calcium excretion from the body through urine. Treatment is use is same, but it is treatment. Again, I am repeating, treatment of osteoporosis, but not prevention. Hypercalcemia, because for any reason, if there is hypercalcemia, it will take the calcium out from the body, and same with the Paget's disease. Side effects are more important. First one is transient rhinitis, nose, because it causes the inflammation of the nasal mucosa. When we use it, intranasal sprays. When we use calcitonin, intranasal sprays, it causes the transient, means for short duration, the rhinitis. That is quite common. Second one is flushing of the face.
So doctor, we delete it if you use it subcutaneous or intramuscular? Just
Intranasal is with
yes,
rhinitis.
only the
Yeah. It is local effect.
What do you mean by flushing?
Yeah, I'm coming to this point. Flushing of the face, tomato-like face.
Tomato?
Tomato or tomato? Or potato or potato. Tomato-like face and redness. And it is directly related with hypersensitivity. Why? Because there is vasodilation. Histamine release. Why? Because we say the source is outside. Fish is the source, so there could be allergic reactions. There could be histamine release, and that can lead to flushing of the face, as well as sometimes allergies or hypersensitivity. Yeah, it can cause bronchospasm. Very good. Even it can cause bronchospasm. Anything that is related with hypersensitivity, it can be caused. This is second drug that is used for the treatment. Denosumab and this one, they are used for the treatment. Again, the duration may be 6 months or maybe 1 year. That's it. We don't use it for longer duration because it is treatment. Next, PTH or parathyroid hormone, as you discussed with Dr. Fateh, it plays very important role in the calcium regulation. We have two parathyroid hormone. These are synthetic analogs. They act same like parathyroid hormone. First one is that is mostly commonly used is teriparatide. And the second one that is just recently added to the market, that is abaloparatide. They are the best treatment option. Best treatment option. But the problem is marra ghali. Maybe one injection 10,000 Saudi riyal. Marra ghali. Karam ma fi mushkil fulus. He is rich man. Okay. Second important thing. Up till now, the drugs that we discussed, they mostly act on the osteoclast. They reduce, they inhibit, they interfere, they prevent osteoclastic activity. Teriparatide and abaloparatide has nothing to do with osteoclast. What does it do? It increases the osteoblastic activity. It increases the osteoblastic activity. Stimulate the osteoblast function by increasing collagen and reducing apoptosis. Reducing apoptosis of the osteoblast. So it is opposite to the bisphosphonate, because bisphosphonate increases the osteoclast apoptosis. It decreases the osteoblast apoptosis. So less death of the osteoblastic cells. Okay, it is approved for the treatment of all types of the osteoporosis in men and women, and what I told, possibly more effective. It is the best option. It is the best option in the treatment of osteoporosis. Treatment. One thing. Secondly, we don't use it in combination with bisphosphonate. You will never see that bisphosphonate is given together with teriparatide or abaloparatide, because they cancel the effect of each other. One is acting on osteoblast, the other one is acting on osteoclast. So one thing. Second one, it also causes hypercalcemia.
Second one?
It also causes hypercalcemia, while bisphosphonate is used to treat hypercalcemia. That reduces hypercalcemia. It increases hypercalcemia. Transient, but that is important. One thing. Second, we don't use it for more than 2 years. We don't know for more than 2 years. But bisphosphonate, we use it for many years. Treatment as well as prevention. Here it is only treatment. What is the problem with teriparatide apart from fulus? Second important thing,
Low tears.
complex administration, because you need to give it intradermal are subcutaneous, and you know the patient is elderly, the patient is suffering from other problem, the patient forgets, so that is called complex administration. Above this, storage problem. What do we mean by storage? You need to keep the injection in the refrigerator. A refrigerator, not freezer. You have thalaja at home. It has two compartments. The lower portion is called refrigerator, thalaja. The upper portion is called freezer. Freezer temperature is less than 0, in minus.
Yes.
And in the fridge, the temperature is from 3 to 7 degree. You need to keep it in 3 to 7 degrees Celsius. If the patient is elderly or forgets and he keeps it in the freezer, gone. Why? Because once it freezes, its effect is gone. So that is important. Again, if the patient can afford, the patient can manage, it is best option for the treatment. And it is used only for 2 years. So again, the patient will come where? To
Two.
bisphosphonates. After 2 years, the patient will continue with bisphosphonates. So, if you can't remember anything in this whole lecture, just remember bisphosphonate. Because you will find in your clinics very common. Because you see oral problems are more common when we get older, especially in females, and here, mashallah, even downstairs, more female patients as compared to male patients. So, and they use it. Why? Because osteoporosis is very common. So that is our story for osteoporosis. Thank you. And then inshallah we will start our PBL by 10. Huh? Who is in my group? Okay. So where is room? Maybe some of the PBL room, huh? You can take.
ايوه
10 o'clock, huh?
ان شاء الله.
Yes.
in the types of bisphosphonate, isodenate, 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 do you need to remember the time, like 1 year or more?
No. You don't need to remember.